First, okay. I love it that this is how I'm taped. All right, so I am super excited to get to introduce Dr. Philip Chan. He is currently an associate research scientist at the Department of Neurology of the Yale School of Medicine. He obtained his medical degree at the Chinese University of Hong Kong. He completed his fellowship training in internal medicine and neurology at the Queen Elizabeth Hospital of Hong Kong. And before joining the Yale School of Medicine, he served as a research fellow for neuro-HIV studies conducted in Bangkok, Thailand. And he completed his PhD in neurologic impacts of acute HIV infection at the University of Amsterdam in 2021. And between 2018 and 2022, he's also worked with the Hong Kong University of Science and Technology on neurodegenerative disease research projects. So Philip, do you want to share your screen?
Thank you, Nia, for your very kind introduction.
Well, we're very excited to hear about what you're going to talk about today, which is your title, the Framingham risk score-based vascular outcomes in acute versus chronic HIV cohorts after 6 years of ART. So with that, Philip, I'm handing it over to you.
Thank you. Thank you for having me, and it is my pleasure to share the research findings related to vascular risk factors in two very different HIV cohorts conducted in Thailand. So very similar to high-income countries, with the implementation of universal antiretroviral therapy and the consequential improvement of life expectancy in people with HIV in Southeast Asia countries, the aging population of people with HIV is expanding. A projection analysis done in 2017 showed that the mean age of HIV population in the area rose from 32 years old to 41 between year 2000 and 2013. And the projected mean age by 2025 will be 45 years old, with 1/3 of them above the age of 50. With the expanding aging population, the healthcare need for non-communicable disease is expected to scale up, and particularly for malignancy, cardiovascular disease, and mood disorders. And we learned from different landmark studies that antiretroviral therapy. Oops, sorry. We learned from different landmark studies that antiretroviral therapy and viral suppression is inadequate for a completely normal, healthy outcome for people with HIV. And in fact, non-communicable disease remain much elevated in people with HIV on stable treatment. For example, coronary artery disease and stroke remain elevated in people with HIV despite careful adjustment of HIV suppression status. And the timing of the antiretroviral therapy initiation or early ART treatment is important. We learned from the SMART trial that ART deferral until the CD4 count below 250 and episodic antiretroviral therapy actually would significantly increase the risk of cardiovascular complications in people with HIV. And besides, lower nadir and current CD4 T cell count are associated with various cardiovascular risk factors, including diabetes, hypertension, and metabolic syndrome that include both blood pressure abnormalities, lipid abnormalities, overweight, and insulin resistance. And one interesting finding from the START trial that compares the adverse outcomes based on a CD4 cutoff of 500. In that study, it can only detect a very marginal benefit in reducing cardiovascular complications even when the antiretroviral therapy was started above the CD4 count of 500. It raised the question whether the adverse effects of HIV infection persist even ART is initiated and maintained during very early phase of infection. So this is a very simplified diagram illustrating the factors contributing to cardiovascular disease in people with HIV. And on the left, it shows the behavioral factors, treatment ART factors, and HIV factors. So now there is growing evidence suggesting that residual low-level viremia or viral activities persist in people with HIV on stable or suppressive treatment, giving rise to the persistent immunoactivation. And some of these mechanisms, such as gut microbial translocation, CD8 T cell activation, macrophage activations can directly or indirectly contribute to conventional cardiovascular risk factors, such as diabetes, hypertension, hyperlipidemia, or metabolic syndrome, and eventually leading to atherosclerosis and cardiovascular disease. And we learned from previous study that immediate treatment during acute HIV can lead to a much better CD4 T cell count and a higher CD4 T cell, higher CD4 CD8 ratio, a significantly smaller HIV reservoir in the PBMC, and much reduced levels of plasma immunoactivation markers when compared to people who start treatment during chronic HIV infection. So the research question we have here is that could very early ART treatment during acute HIV infection reduce the cardiovascular risk factors in these people with HIV? And instead of comparing these cardiovascular risk factor parameters individually, is there any way to be more informative for policymakers, say, for example, whether or not we could quantify these cardiovascular risk factors into a summated format? One solution is to summate these cardiovascular risk factor using the 10-year cardiovascular risk by percentage. And this is actually a very frequently used clinical tools to calculate the overall 10-year risk of a person's using the conventional cardiovascular risk factor. And the atherosclerotic CVD score or the ASCVD score and the Framingham risk score are the two frequently used tools in clinical settings. Both of them are basically based on a very similar set of clinical parameters, including the age, the sex, the cholesterol level, the blood pressure, and the use of antihypertensive treatment, status of smoking, as well the diabetes. One key difference between the two methods is the output parameters. Both of them could provide a 10-year cardiovascular risk by percentage, but for Framingham risk score, it can also generate a raw score, a total score, as well as a vascular age. And for those, this slide illustrates how Framingham risk score is calculated. It is basically generated from the subscore as shown in the top right-hand corner. And we try to, in the clinic, we will match each of the risk factors on here and add up all the subscores to get a total score. And when we get and then we would convert the total score here on the right lower corner to the parameters we look for example, the 10-year cardiovascular, the 10-year risk, as well the vascular age. The vascular age is of an individual is actually represent the age of an individual with an age with optimally controlled cardiovascular risk factor. Just for example, I'm 40 years old, but I have multiple cardiovascular risk factors and leading to a similar 10-year cardiovascular risk of a person who have of a 45 years old person, then my vascular age will be 45 years old. And the vascular age deviation is calculated by using the vascular age minus the actual age, and it is a measure of it can be considered as a measure of vascular health between individuals irrespective to their chronological age. And one important thing to note for the vascular age in the Framingham risk score is that there is the lowest provided age will be 30 years old. So in the upcoming analysis I showed you, for those who have who had a actual age of younger than 30 years old with perfectly controlled cardiovascular risk or a Framingham risk score lower than 0, we will use their actual age to represent their vascular age. And recapping the study objectives, this study we are going to compare the Framingham risk score based parameters, including the 10-year risk, the vascular age, and the vascular age deviation between people with HIV who initiate ART during acute HIV infection and chronic HIV infection. And it's in the exploration proportion of the analysis, we will apply multivariable analysis to identify independent predictors of vascular age deviation. Regarding the method and participants, this study, we include participants from 2 longitudinal HIV cohorts conducted in Bangkok, Thailand. The first one is the RV254 acute HIV cohort with around 700 participants, and the other cohort is the HIFNet 006 chronic HIV cohort, which include around 1,800 participants. And both of them are longitudinal cohort, and regarding the selection criteria, we only include those who have completed a 6 years follow-up. And because of the different follow-up schedule in the 2 cohorts, for the RV254, that would be the week 288 follow-up. And for the HIFNet cohort, it will be any follow-up with the complete cardiovascular risk data between 5 to 7 years. And all of these participants had to be virus suppressed in order to be included in the data analysis. One thing it is quite different from a lot of previous study that would include all participants in the cohort. But we try to not to take this approach because in these previous studies, one of the major limitation is that there is survival effects and there's collinearity between these participants. For those, for example, who have a higher CD4 count, they usually have a longer duration of ART and they are older. So we try not and by applying this setting by fixing the follow-up period, we've tried to fix these confounding factors. And this table shows the baseline characteristics of these participants between 2 cohorts. There are some key difference between the 2 cohorts, including the age and sex, the CD4, the T cell counts, and the CD4-CD8 ratio. And there is some slight difference in terms of percentage between diabetes, hypertension, and smoking. And this table shows the participant characteristic at 6 years follow-up. Again, the participants in the acute HIV cohort, because of the earlier treatment, they demonstrate a much higher, significantly higher CD4 T cell count, as well a better CD4-CD8 ratio. And they also have different pattern of co-infection. For example, hepatitis B and tuberculosis infection are more common in the chronic HIV cohort, while syphilis infection it was more common in the acute HIV cohort. And as the chronic participants in the chronic HIV cohorts were older, they also showed a higher percentage of hypertension, diabetes, and the use of higher percentage of statin use at the time of 6 years follow-up. We also observed a higher 10 years cardiovascular risk percentage in the chronic HIV cohort. However, in fact, only 90, but actually they're actually of a very low risk, and up to 90% of participants in both cohorts were categorized as a low risk of cardiovascular disease. And when we compare the vascular age deviation by removing the effect of actual age, we did not observe any difference in terms of the vascular age deviation between the two cohorts. So because of the difference in age and sex between the two cohorts, we additionally developed a age and sex match cohort to test if the vascular age deviation are the same between the two cohorts. And as shown here, even we use a perfectly matched cohort participants, we could not show a statistically higher vascular age deviation in the chronic cohort as compared with the acute cohort. So this recently published report provides a very important collateral information to interpret how good or how bad is the Framingham risk score outcomes among these participants when compared to the general population. This study included 300,000 Royal Thai Army personnel, and the investigators evaluate their Framingham risk score among them, and they are all over 30 years old with no known history of cardiovascular disease, and the mean age of these 300,000 Thai Army personnel was 43 years old with 90% male. And the cigarette smoking frequency is a lot higher in this group, which was 28% versus 13% in the acute cohort and versus 18% in the chronic HIV cohort. This very busy table showed the 10-year cardiovascular risk percentage by age in the Thai Army personnel study. If we compare the risk percentage with each of the cohorts, it is like 3%, 3 to 3.5% of 10-year cardiovascular risk in the Thai Army data versus 2.3% of 10-year cardiovascular risk in the acute HIV cohort. And also it was around 5 to 5.5% of 10-year cardiovascular risk in the Thai Army data versus 2.8% in the chronic HIV cohort. So to summarize, we find that actually 90% of participants in the two HIV cohorts actually had a low cardiovascular risk 6 years after treatment. And compared with people without HIV, the Royal Thai Army data, these participants demonstrate a comparable or even better 10-year cardiovascular risk by Framingham risk score at the 6 years follow-up. And comparing the vascular age deviation between the two cohorts, we did not observe any additional benefits in terms of cardiovascular risk in the acute HIV cohort, despite they start the treatment during acute infection. And then we ran the univariable and multivariable analysis to identify factors independently that's independently associated with the vascular age deviation. And the factors include in the univariable analysis include the BMI, the body mass index, the treatment type, the early versus delayed treatment, whether or not they have report any drug use and any substance use, and the CD4, the T cell levels, CD4 CD8 ratio, co-infections such as hepatitis B, hepatitis C, and also exposure to different antiretroviral drugs, including the protease inhibitor, NNRTI integrase inhibitor, and abacavir. So what we do here is that after the univariable analysis, we run multiple multivariable analysis in model 1 to 5, adjusting the collinearity or association between cohorts and BMI, antiretroviral therapy, and co-infection, etc. What we find is that, or a little bit counterintuitive, is that we find that higher CD4 count at the time of 6 years follow-up was associated with a higher vascular age, which is in normal circumstances, we would expect people with lower CD4 count would have worse cardiovascular outcome. And we try to look into the potential association between the higher CD4 count and vascular age deviation between acute and chronic cohort, and between smoker versus non-smoker, because there are previous studies reporting the potentially higher CD4 count in smokers. So on the figure on the left show include all the participants and categorize them into and non-smoker in red and smoker in blue. And as you can see, no matter we compare, we look into the association between CD4 T cell count and vascular age deviation between different cohorts on the right here, and between smoker versus non-smoker, we could still see they have shared a similar trend of higher CD4 count and higher vascular age deviation. So to summarize, apart from the 10-year cardiovascular risk outcome, we find that higher CD4 T cell count is independently associated with higher vascular age deviation, and the trend appears to exist in both acute and chronic HIV cohort participants, as well as smoker and non-smokers. And it is completely a speculation, but one thing that may worth further investigation is to look into whether or not certain CD4 T cell subsets, expansion, and the cardiovascular risk outcomes. And but it is quite beyond the study perspective here. So the limitation of this study have to be emphasized. First of all, most of these participants are below 40 years old. So we do not know if the age effect, whether or not the age effect will compound on their cardiovascular risk outcome when they grow older. And the two cohorts are not perfectly matched in terms of sex and age. And also they have different patterns of co-infection and antiretroviral therapy usage. And lastly, this study, although we captured the longitudinal outcome, it is a cross-sectional study and only focusing on the Framingham risk score 6 years after treatment. So we could not pull, it cannot tell whether or not, say, for example, on a longer run, whether or not the outcomes would deviate between the two cohorts. So this is my last slide, and I would like to thank all our participants and the two on-site team who take care and follow up our participants, and most importantly, our data analysts who help bridging the two cohorts data to run this cross-cohort analysis. Thank you.
Thank you, Philip. That was an amazing talk. I think we have time for probably one or two quick questions before I introduce Lindsay. I think Jules had a question in the chat. Or maybe just more of a comment about needing to focus on people over the age of 60.
Yeah, I think this is a very important question. And I must say, for the acute HIV cohort, we do not have the power to answer this question because they are too young. What I didn't show for the chronic HIV cohorts, the HIFNet 006 cohort here, in fact, as I mentioned, they have more than 1,800 participants, and as far as I know, over 700 of them are older than 50 years old. So they, the HIFNet 006 cohort could be a very good aging HIV cohort to look into the aging questions. And hepatitis C and hepatitis B infection, yeah, that's true. And actually, there is quite a lot of hepatitis C infection in the, at least in the acute HIV cohort, and we do see reinfection already. But one limitation I would say in terms of looking into the hepatitis C outcomes in Bangkok or in Thailand is that the hepatitis C treatment is only recently available for the patients. So
so my point was that both hepatitis C and hepatitis B co-infection cause inflammation and contribute to accelerated or premature aging. So I think that and looking at people over 60 who have a double hit from being over 60 and having HIV and all the abnormal inflammation, I think those things contribute a great deal to a difference between chronic or acute. And those groups probably cause much higher rates of cardiovascular disease. And you said 90% didn't, but you were looking at people who are average 43. Once you get over 60, the whole picture changes.
Thanks, Jules. Yeah. I'm going to put that in the, I hate to kind of push things along, but if we can take this into the chat, please ask additional questions to Philip. Thank you again so much. Now we're going to turn, I get to introduce Dr. Lindsay McAlpine, who is a neuroimmunologist and an instructor in the Division of Neurologic Infections and Global Neurology at Yale, Yale University School of Medicine. And she started a neuro-COVID clinic at Yale in October of 2020. And she sees patients with neurologic issues related to long COVID. She's an investigator in the COVID Mind study at Yale, and her research interests are related to the pathophysiology of cognitive impairment after COVID-19 using several modalities, including MRI. So we're going to hear from Lindsay about neurovascular dysfunction and neuropsychiatric post-acute sequelae of COVID-19. Thank you, Lindsay.
Yeah, thank you for the intro, Leah. All right, thank you so much for having me. I'm excited to present this preliminary data. So I'll be talking about the neurovascular dysfunction in long COVID. I don't have any relevant disclosures. And so first I'll kind of go over what is neuropasc. So the WHO definition is any symptom that lasts for longer than 2 months, not explained by something else, and present at 3 months after COVID. You know, with people who were infected in 2020, we're going on 3 years, in some cases, 3.5 years of long COVID. The CDC definition, they had a similar one, and then they took it away, and they're defining things more broadly. Almost every organ system is involved in long COVID, and this is one of the reasons, among others, that a vascular etiology would make a lot of sense for some of these symptoms and organ involvement. So in acute COVID, we early on figured out that the vessels in the brain were significantly affected. So there were numerous postmortem MRI and pathology studies demonstrating significant microvascular damage and dysfunction in the brains of individuals who died of acute COVID. So we know in like the really terrible infections that there's congestion, activated microglia, and then inflammation of the endothelium leading to lymphocyte infiltration into the brain. So this was pretty significant in the patients with a really acute ICU illness, and studies have shown that there's some flavor of that in people who are less sick at home and in the hospital. And so how do people present after COVID, after they recover from this acute illness? There's a very clear cognitive syndrome. So people describe word finding difficulty, inability to multitask, difficulty with paying attention and remembering conversations, things that people just said, forgetting whole conversations, and just an overall slowing. And, long COVID is really a hard thing to study because it's similar between most people, but everybody's long COVID experience is different. And there's a number of confounding factors like sleep, pre-existing medical conditions, mental health conditions, and others. So these are the typical domains affected in individuals with long COVID. So this is a more recent study that was very interesting and something we were already looking into. But they took 24 patients with persistent cognitive complaints, and they did perfusion imaging in the brain and found significant hypoperfusion in a widespread network, predominantly affecting the frontal cortex as well as the parietal and temporal cortices, and the involvement was more extensive in the right hemisphere, which is something we also observed in our preliminary data as well. And very interesting that we're finding something that does actually correspond with patients' symptoms. This is not typically done as a clinical sequence in a regular MRI of the brain. So most of these patients have pretty normal MRIs. And this really does support our hypothesis that there's a large network dysfunction involved in the cognitive complaints, and there is a vascular component to it. So overall, what have we ruled in, what have we ruled out of the numerous proposed mechanisms of neuropasc? Systemic inflammation is definitely one. So the damage done during the acute illness and the disimmunity or the dysfunction of the immune system afterwards. Vascular damage and dysfunction, definitely. Autoimmune inflammation towards the peripheral nervous system. We have found autoimmune small fiber neuropathy after COVID. Viral antigen persistence. They've shown this in the lymph nodes in the gut, that there is antigen persistence. There is no evidence of ongoing viral replication, but this antigen persistence kind of smolders and fuels the immune system. Unlikely neuroinvasion. In very, very rare cases have we found viral antigen present in the spinal fluid, and it was only in individuals who had a severe acute illness with, like, they were on ECMO and they had reasons for blood-brain barrier breakdown. And then autoimmune inflammation towards the CNS. We just published a paper in JAMA Network Open Shelley Farhadian's work showing that there is no evidence of ongoing inflammation in the central nervous, in the spinal fluid in individuals with neuropsychiatric long COVID symptoms. Okay, so going into our study, we've got a multifaceted study. So we've got MRI, neuropsychological testing, looking at the clinical history and surveys, looking at blood work, and cerebrospinal fluid. We're recruiting individuals from the community for both controls and participants, and as well from our clinics. Our participants have a positive history of COVID, so we're not taking COVID negative individuals or people without a positive test, and then individuals who have a neuropsychiatric symptom after COVID, and then the controls are COVID positive and PASC negative. So they have a history of COVID, but they have no evidence of PASC. And then we're doing the neuropsych testing, the battery of assessments, the LP when people are willing to participate, a blood draw, and an MRI. The MRI we're only doing in individuals with this cognitive impairment. So we're not doing the people with headaches or anosmia or other mood symptoms. So the background for I'm going to go into our vascular, the vascular inflammation in NeuroPASC. So this is our whole COVID-19 cohort. So they had a variety of symptoms, neurologic and psychiatric, and we looked for biomarkers of endothelial and platelet dysfunction. And we know these are elevated in individuals with acute COVID, but we were looking to see, is this persisting in long COVID? So we investigated for this. We investigated participants who had, by the WHO definition, had neurologic PASC, and our controls had a history of COVID and no PASC. The tests were ELISA based on plasma, and these were the markers that we measured through a panel at Eve Technologies, and then we used non-parametric testing. We had in the PASC group 40 individuals, in the control 16, and they were similar in age, gender, ethnicity, race, days since acute COVID illness, whether they were vaccinated before, slightly more vaccinated in the PASC group, and then similar in their vascular risk factors, which I think is important to take into context with these types of tests. And in terms of their long COVID symptoms, there were a variety. So the most common symptoms were fatigue, poor concentration, poor memory, word finding difficulty, new or worse anxiety, headaches, poor balance, and peripheral numbness in the extremities. And these are our results. So we had a number of significant differences between the groups. The red is the PASC group, the blue is the control group. So alpha-2 macroglobulin, CRP, fetuin A36, haptoglobin, L-selectin, PF4, platelet factor 4, and serum amyloid protein as well. So it's important to note the fetuin A36 is the lower marker, is a measure of higher risk. So this is going in the right direction. So to summarize, we found key differences in vascular inflammatory plasma biomarkers in individuals with neurologic PASC, and we found differences in plasma proteins that indicated ongoing systemic inflammation. So CRP, haptoglobin, SAP are markers of systemic inflammation. Endothelial dysfunction is represented by alpha-2 macroglobulin, and then markers of accelerated atherosclerosis are L-selectin, phetuin ACE36, and SAP as well. So this brought up questions. So interesting, confirms the hypothesis we have, but brings up questions. Are individuals with PASC at a higher risk of persistent vascular inflammation, the smoldering inflammation, and or how does this relate to atherosclerosis and future vascular risk, future vascular disease risk? So, we'll be looking to study these individuals longitudinally, and then sending additional markers to see if we can tease out, is it the endothelium, is it the different vascular pathways as well. So moving on to similar, but slightly different topic is our MRI data. So we enrolled the individuals in our vascular cohort who had the cognitive symptoms. So this is a subset of the individuals I just talked about, but they specifically had to have cognitive impairment and cognitive complaints, and similar control group as well. And we did arterial spin labeling to measure parenchymal perfusion in the brain. And then we use non-parametric testing to test between regions. Again, the age, gender, and ethnic breakdown was similar between groups. We had 18 in the PASC group and 13 in the control group. So here is a sample of what we're looking for. Starting at the bottom of the brain going up. And the red is higher perfusion, darker is lower perfusion. And so we're comparing these maps and the regions between groups. So in our preliminary data, we showed a more right hemisphere predominance, and then with 10 more individuals, it's localizing to the superior parietal lobule, and that shows a significant hypoperfusion in the PASC group compared to the control group, which I find very interesting. This trend of lower CBF gives us an insight into the symptoms, because lesions in this area can lead to visual spatial disorders and issues with episodic and semantic memory. So in that processing, in that word finding, and it fits, which is interesting. And we'll see as we recruit and enroll more individuals if this or other regions become regions of interest. But typically in MRI studies, we need more numbers. So this is preliminary. So the limitations is it's preliminary. We have a smaller sample size, and unfortunately we don't have pre-pandemic controls, or I should say scans. It would be really helpful to have pre-COVID scans, post-COVID scans, and then a longitudinal. But this is a common issue in our long COVID field as just as an entire field. It absolutely takes a village. Dr. Serena Spudich is my mentor, and Shelley Farhadian. We work all together closely with our group, and Leah Rubin and Todd Constable. And we look forward to continuing this study.
Thank you, Lindsay.
Yeah.
I'm going to open it up to questions. It's fun to see as the preliminary data keeps emerging as your numbers.
Yeah, and how it kind of shapes
fun to
up.
see.
Like,
Yeah.
looking at the questions.
Aaron, do you want to unmute yourself?
Yeah, sure. Can you hear me?
Yep.
Great. Thanks for the talk. That was really great. I just wanted to know why the hyperperfusion is localizing to those particular areas, if you have any ideas why.
Not yet. No, I don't have, you know, I can't. I'm not sure. You know, I think that's a really good question and something we've been thinking about a lot. And, you know, I think we're just beginning to map long COVID, you know, and understanding the regions can help us dive deeper into that because, you know, we were dealing with this with addressing multiple comparisons is, you know, if we're studying Parkinson's, we can study the basal ganglia and the brainstem, right? We have a target. We don't have to go broad, but with long COVID, we had to go broad because we didn't know where we were looking for necessarily. And so I think this gives us an idea where to look and further understand from there. But no, I'm not sure yet why is it this region that's more affected than others.
And then Lindsay, I think in the chat, Jules.
So I just answered one of them.
Okay.
So the majority were vaccinated. So 80 to 80% in both groups were vaccinated. And then increased amounts of female.
No, but that's not my question. My question is if vaccinated people had less worse outcomes as measured by your biomarkers.
Oh, that's a good question. I haven't looked at that sub-analysis yet. If that was a protective, you know, we started recruiting before the vaccine. So quite a few people are pre-vaccine, but that's a good question.
Well, I think it's critical today because most people in HIV at least, who are HIV positive, are vaccinated, and that's my other question. Do you think people with HIV have worse outcomes than people without HIV?
So we had no individuals in our study with HIV, and I think Farhan is going to be addressing that question from our group. And that's a good question about the sex differences. You know, it's long COVID is in general more prevalent in women of, I mean, I would even say reproductive to menopausal age. That's like the majority of our group, which bears a significant parallel to, you know, my MS and neuroimmunology patients as well. So, you know, I do wonder if there is some level of dysimmunity or autoimmunity that's really playing a role in this, but to be determined. RNA markers of COVID in male versus female. What kind of RNA markers?
Fatah, do you want to expand?
Yes, I'm very sorry. Yes. So I would say the S gene, anything at the 3' end of the genome or the N, M gene maybe, but mostly N and S. Open reading frames.
We haven't looked at that yet, but that's we have our participant samples in repository, so we're always looking at new questions to ask. What do you think it could help us figure out?
Well, I'm one of those people that believes the RNA could be integrated into the genome. And I can see that in vitro in tissue culture and in 3D infections. So
yeah.
The question becomes, at some point, did some of these COVID RNAs become cDNAs and integrate into the genome? And if so, then, and I don't know which cells to look at, that's the tough part. But at least there should be markers of RNA or potentially DNA in these cohorts.
And how it alters transcription. Okay, yeah. That's a good question. Would you look in some lymphocyte progenitor, something like that?
Exactly.
I feel like people are doing that, maybe. Good look. Yeah. Thank you.
Yeah, thanks.
Howie, and then Bob.
All right, Howie Endelman from Nebraska. It was great talk. I just was curious regarding your pathogenic mechanisms, the vascular etiology, and I was wondering if you actually looked at these biomarkers in other types of vascular disease to see what the commonalities might be.
Yeah, that's a good question. And when we were sending this, we were looking up, and the most robust literature is in cardiovascular disease. So in the heart. And so we're kind of, we take what's been done in the heart and we apply it to the brain vasculature. They're usually on the cutting edge. And then so this panel, I think, was designed with that in mind.
Thanks.
Thanks, Howie. Bob?
Yeah, thank you. Very, very interesting talk. I was wondering, as a non-imager, whether it's possible, since your groups are small and you're looking at averages, right? And there's variability within the groups.
Yeah.
And some people may not even have hypoperfusion in the NPAS group.
Right.
And I wonder if it'd be possible to take the individual people in the NPAS group and compare their scans with the average of the comparison group, and then look at how they relate to those findings. Localized findings may relate to the cognitive reports. They're not
I like that idea.
Objective cognitive data, right, Leah?
Yeah.
Yeah.
Yeah. In fact, she's got a fully RDoC battery
Right.
to be able to dig into.
Yeah, I talked about it last time, but I have the slides too, but yeah.
Okay. So anyway, I think that it's a pretty gross look at it when you're looking at small
I
groups
agree.
and averages and blah blah. So that's all. Thank you again for
So interesting. I like that idea. And then I was obviously intrigued by the voxel based comparison as well. But I have to talk to our team to see if that's how we go about that as well.
Awesome. This has been amazing. Katie. Oh.
Yeah.
What did she say?
Oh, sorry. I was just going back to the RNA markers. So that was something new to me, and I didn't know if that was something you could actually measure in circulating blood, or would you need specific target cells? I guess that's a question for Fata. Sorry.
Yeah, sure. So the RNA can be purified using oligo-DT columns. So that's one way of doing it. And that way you would enrich it, not just doing a straight RT-PCR, but enrich, going through some kind of front-end purification. I don't know if one can do this in humans. I certainly do see it in vitro, and I can increase the sensitivity by 2-3 logs when I do oligo-DT purification. In terms of what RNAs, it really depends on whether the genome has integrated, and is it a single copy or multiple copy. In terms of the target cell, again, in vitro, I can show, or at least I've seen myeloids, I've seen astrocytes, but then again, I don't know if that's real in vivo. So I guess if I would to do this in blood, male versus female, I would do an oligo-DT purification of the mRNAs first, and then look for markers at the 3' end of the genome. And the most abundant are going to be the S gene and the N gene, most likely the N. And then maybe M as in mom, but I would put my money on the S gene. and the NG, excuse me, NG. But then again, I don't know. I mean, to me, it's amazing that we still have these symptoms for so long, and one can see this in vitro as well. So I don't know if it's real in vivo.
Yeah, definitely.
Very interesting. And can you just sorry, since
you're fine.
Lindsay, so the NeuroPASC definition, that was anyone who had, PASC in any of the neuro symptoms, including the anxiety, depression, paresthesia.
Usually, yeah, most people had multiple, right? So it's like they didn't just have one of those. So like we didn't, so there was a lot of overlap between, which is why I showed the prevalence of each symptom. But everybody is kind of like, some people have the anxiety and the headache, some people have the neuropathy and the fatigue, some people, so it is ends up being a heterogeneous group. Yeah.
Which is also, really impressive that you found differences, right? So
yeah.
Which is also why large scale studies are needed, right? Because it's like anything, there's so much heterogeneity here that there's likely to be alterations, and it's in which subgroups and what are the it's the same issue that we have in HIV, that, and then how that kind of plays out in these other conditions. So this is great, Lindsay. I don't know, this has been great discussion, both on your talk as well as Philip's. So thank you guys both for coming back and speaking. Cassidy, do you want to
sorry. So next week we have we had a little change. Oh no, not next week. We didn't have a change. We have Mohammed Savan Andalabi and Azin Tavasoli speaking. I don't have their topics yet, but I'll be sending those out shortly.
Awesome. So thank you guys for spending your lunchtime with us, and have a great rest of the day, and we'll see you guys next week.